and welcome to another episode of MedSynapse podcast series, where we bring you insights from top medical experts across the globe. I'm your host, Hetvi Shah, and today we are diving deep into a topic that serves as a true lifeline for many, which is navigating access to good treatment centers for blood cancer. And to guide us through this crucial discussion, we have with us Dr. Sachin Jadhav. He was a CMD and CEO at Chiron Oncology Center. Dr. Sachin is a renowned expert with 21 years of experience in hematology and bone marrow transplantation. He is also the chairman of International Hematology Consortium with over 800 bone marrow transplants to his name and an establishment of 15 BMT centers across India and Tanzania. He's at the forefront of ensuring access to world-class treatment. Dr. Jadhav is the group head of HCG Group of Hospitals and chairman of Marrow Matters Private Limited. So, yes, welcome, Doctor, to the podcast. And to start with, could you share a bit about your professional journey and what led you to specialize in hematology and bone marrow transplantation?
Yeah, thanks for this opportunity, Hetvi. It's nice to discuss, the details of what we do with you. So I'm from Mumbai. I did my MBBS in Rajiv Gandhi Medical College in Kalwa, and then when I was doing that, I realized that oncology is truly a branch of medicine. It was a branch of medicine which was growing very rapidly. And it's always interesting and exciting to try and participate in something that is evolving and that can transform the lives of so many patients. So that's how I chose to be in oncology. I did my internal medicine training in Pune, BJ Medical College, and then went out to CMC Vellore, where I had my major grounding in hematology and bone marrow transplantation. Then, with a brief training abroad in Vancouver, Canada, and in London, UK, I came back to India with the thought that we should do good work, and good work being ultimately defined as a clinical outcome which is at par with any center in the West. I was very clear that I don't want to be one of those doctors who will come back and say, in India we can only do this, or our nurses are like this, our doctors are like that. I mean, if I've taken all of this training, I might as well do a good job and ensure that no patient's family should feel that. If I would have taken my father to New York or Sydney, maybe he would have been cured. They should not have that feeling. So our chances of success or failure have to be the same as anywhere in the West, in any developed country, at a fraction of the cost, right? Because we are all poorer developing countries and we really can't spend the way these other countries spend. So, good clinical outcomes at a fraction of the cost. That is how I started my career.
Yeah, that's such an inspiring journey, Doctor. And I think your dedication to this field is also very commendable. So to start with the main discussion, Doctor, you have played a pivotal role in establishing 15 hematology and BMT centers across India and Tanzania. So, what was some of the biggest challenges you faced in setting up these centers, and how did you ensure that they met international standards also?
Yeah, that's a very good question, Athvi. Of course, it happened by chance. I didn't set out 10, 11 years ago saying, hey, look, we are going to do so many centers. My first department in Bangalore, I decided that we should be audited independently, and a proper accreditation facility, like there is an accreditation called FACT accreditation in the US for bone marrow transplant. They should come and audit us and tell us if we are really good or not, right? So we cannot say that we are as good as anybody else. It has to be an independent audit and accreditation. And I think that sets a benchmark as the standard that we have to deliver. Now, To develop that standard, you have to kind of re-engineer the way medicine is practiced in our part of the world. And unfortunately, the what we have been doing for so many years, and what we continue to do in most of the places in most of the developing countries, is there is one senior doctor, who gets treated as god and who believes that he is god, and all the good and bad things that could happen to a patient are kind of pivot around this one individual star doctor. But that's not how medicine is practiced around the world. Around the world, doctors are just they're just another professional entity. They're nothing bigger or smaller than say somebody who's driving or who's a plumber. Everybody has their dignity of work, and that just settling down the ego of your team, saying, hey, look, we are here to do a good job, and the fact that I am not at the center of it, and we have to work as a team. We have to create policies and protocols, and we will all adhere to those policies and protocols, right? So even I can't change a protocol unless I have a meeting, I have a discussion, I provide data saying, hey, look, for this patient, this complication, we should treat in that manner and not as per protocol. So you kind of set up standards for functioning. And but that's a very different way of working, and our healthcare, it probably doesn't work in that manner. So that itself was the biggest challenge, and holding yourself and everybody accountable. Yeah.
Yeah, I think overcoming these challenges must have required great vision and persistence also.
Yeah.
That's really incredible. So now, blood cancer patients often struggle with low immunity, which makes their treatment journey even more complex. So, what strategies have been successful in managing these issue effectively?
That's a great question, Haitu, because that is the number one cause of death in
Correct.
patients with blood cancer. It's infections, infections, infections. And in our part of the world, where general hygiene, cleanliness, just the purity of water and food, and
Yeah.
and the way we clean our hospitals, and none of that is in place. Ours is a new specialty, right? And so I had to kind of go through a lot of international protocols, the way they function, and adapt it to our setting. A lot of training had to go in to the team, and a very obsessive audit saying, hey, are we all washing hands, and how is the room cleaned, and do we have safe drinking water, etc. So just going into those basics. That was the first part of it. The second part essentially is infections in our country are more difficult to treat
Mm.
because we have bacteria which are resistant to multiple antibiotics. I remember the antibiotics that we used to use in Canada have been useless in India for almost 20 years because bugs just don't respond to them. You can't cure any infection with those antibiotics, and that resistance in antibiotics, and how do we manage that? So we went through this in a very methodical manner, and we continue to do that. So we conducted a lot of research into what antibiotic to use, which combination to use. Along with that, using growth factor support. Along with that, supplementing the immunity with granulocyte transfusions. And mind you, granulocyte transfusions, etc., are not usually done in the West because they don't have major problems with infections, right? But using these novel strategies in a standard manner for every patient who walked in and got treatment, and then putting all of this together into our own febrile neutropenia protocol, which I call it Maggie protocol. So it's easy to remember the elements of what we do. MAGGI. I mean, it's so just to ensure that my entire team follows it, consistently using it for every patient, whether it's 2 o'clock in the afternoon or 2 o'clock in the night, giving that standard treatment has helped us.
I think that makes a lot of sense also. So now, Doctor, the next question is something that is that is very buzzing around. We've been hearing a lot about cutting edge treatments like CAR T cell therapy and even bite therapies these days. So what's your opinion on these advancements? How do they fit into the current landscape of blood cancer treatment?
Yeah, and this is the very reason why I joined oncology, because it was such a rapidly developing field, and it's very exciting. In the last 20 years that I've been in this specialty, our treatment has changed two, three times. Everything has transformed, and we have gone from randomly selecting and choosing and doing clinical trials and critical protocols and refining them, to actually have a genomic and research oriented approach in understanding the cancer cell, in understanding the immune landscape, which because of which cancer cells can flourish in the body, right? Our immunity is not able to kill them. So how do they evade the immune system of the body? And all of that understanding has kind of transformed into bringing in new treatments, which of course includes the great CAR T cell therapy and bite cell therapy. Um, there is no doubt that these novel therapies are phenomenal. They have much less side effects. They work wonderfully. They work in the majority of patients. Having said that, they are far, far too expensive for majority of the patients, right? So most of the patients in Southeast Asia and Africa, 99.9% truly can't afford these treatments. So we of course have these great treatments, and they will be used by whoever can afford them, in whatever way, or people just can't use them. So what we have done essentially is we have created a protocol for treating blood cancer, which I call the Cancer Ground Shot Project. And this is a straight juxtaposition to the Cancer Moonshot Project, which is going on in the US, which was started by Joe Biden when he was the vice president, and they put in billions of dollars in understanding the genetics of cancer and all that. But the ground reality is majority of the patients in the developing world can't use that. So what we did is we created a Cancer Ground Shot Project, and we have created three levels of treatment. So level one is the routine treatment, standard current chemotherapy protocols, which give the best chance of cure, right? And we use it for our patients, and we help them raise money via social media, via crowdfunding. We try to get them free medicines, and we've gotten free medicines worth 5 crores in the last 5 6 years. Our team has done a great job. So we try to help patients with the level one, the basic standard chemo protocol, right? And that's the majority of our patient base. Then level two is slightly more intense. These are patients who can afford more, and they say, doc, I'll try my best. I have the funds, or I can raise the funds. Do as much as you can, and we use some more newer medicines for them, right? Which will be more expensive, but we have less side effects, better chance of cure. And then level three protocol is where we have the super rich who say, doc, whatever you need, you do it, any medicine in the world.
That's
And
right. Yes.
yeah, and today in India we can procure anything that's available in the world. Within a week or two we can get that medicine. So that's the level three protocol for people who say, doc, whatever it takes, you do it. So we've kind of tiered the protocol based on the affordability, ensuring that each level can has access to whatever they can avail of. And at the same time, we are not cutting short their treatment. We are really giving standard treatment, ensuring that the outcomes are good.
Yeah, I think that strategy is really interesting to know because it is so important for the developing countries to actually think for from their perspective also, and then distinguishing it is really interesting to know. So now, Dr. Stem cell transplantation remains a key treatment approach for blood cancer. So could you elaborate on which patients are actually ideal candidates for these procedures?
So, stem cell transplantation, essentially what we do is, inside our bones, we have the bone marrow.
Mhm.
And bone marrow is the factory which makes blood. So, bone marrow makes RBC, WBC, platelets, the three types of blood cells. Now, this factory, if we have to replace this, the good part is we don't have to replace the entire marrow. What I mean by that is, for example, when a liver transplant is done, the liver is removed and a fresh donated liver is put in, right? A kidney transplant involves physically removing the kidney and putting in. However, the bone marrow is a very unique organ. In that, by that, what I mean is the bone marrow has something called as stem cells, hematopoietic stem cells. And stem cells are like seeds. And when you plant a seed in the soil, that seed will give rise to the entire plant. You don't need the whole plant, you just need the seed,
Mm, that way.
right? And the seed will give rise to the flowers and the fruits and the leaves and the roots and everything. Similarly, when you take the hematopoietic stem cell, right, and you put that into the recipient's body, these stem cells float through the blood, they sit in the various bones, and they recreate the entire bone marrow. You just need the stem cells. And that bone marrow then makes new RBCs, WBCs, and platelets. So essentially, we are changing the factory. And this kind of transplant, that is allogenic stem cell transplant, when you take a different donor who is HLA matched, you have to do this test called as HLA matching. And we need at least 50% HLA match in today's world, right? So you have a donor who's 50% HLA match, and you put in the stem cells, etc. A new marrow is formed. Why do we do that? Because this new marrow will give new WBCs, and WBCs are the police, they are the military of our body, right? So you're changing the immunity. And the hope is that this new immunity, the new police, the new military, will be able to identify the cancer if and when it grows back and kill it. Okay? The core concept of cancer is probably all of us get some cancer cells in our lifetime, but our immunity is able to catch that bad cell and kill it before it turns into a terrorist organization. Yeah?
Absolutely.
So the fact that a patient comes to us with cancer means that their immunity failed to catch it early enough. Now you've given your chemotherapy, immunotherapy, and brought down the cancer, probably eradicated it, but it may come back. And maybe in those patients in whom there is a very high chance of relapse, there's a very high chance that the cancer may come back. In those patients, probably it's best to change the immunity with a stem cell transplant
Mm.
so that the new immunity will be able to identify and kill off the cancer cells if they have been left behind, and if probably they grow back, right? So which are the patients who have a high chance of relapse? That is the real answer to your question as to stem cell transplant is most beneficial for which kind of patients. Well, those patients who have a high chance of relapse. How do we know they have a high chance of relapse? By three ways. There are three ways by knowing, all right, this patient has a very high chance of the cancer coming back. First, we look at the genetics. We look at the genomics of the cancer cell, not of the patient.
Mhm.
So
Okay.
the diagnosis of cancer, we do a lot of genomics nowadays, starting from karyotype fish to NGS panels to OGM to understand if the cancer cell has really bad genetics.
Mm.
Bad genetics means this fellow is going to grow back. Yeah, that's one.
Okay.
So cancer genomics. Second, we test how much have we managed to reduce the cancer within 1 or 2 cycles of chemotherapy by a test called as MRD, minimal residual disease. That means within 1 or 2 chemo cycles or so, if the cancer has gone so down that I can't detect it, even with the most sensitive technology, That means it is minimal disease, minimal residual disease is also negative. That means
Right.
there's a great response. That patient does not need transplant,
Mm.
right? So patients who don't have a great control with cancer will need transplant. So cancer genomics, MRD, and lastly, if they've already had a relapse, they've
Right.
received treatment before and it has come back once, it's likely to come back. So these are the three subsets of patients who need a allogenic stem cell transplant.
Yeah. Actually, that was such a clear breakdown also. So thank you for sharing that, doctor. Now, finally, one of the biggest dilemmas for patients in choosing the right place for treatment is like, should they stay focused on the hospital, the doctor, or the team as a whole? So, what factors should they consider?
Yeah, now we are coming back to where we started, that, how do you improve outcomes in patients, right?
Hmm.
Because patients, when they choose treatment centers, where should I take treatment? They look at two things. Will I get the right treatment with the best chance of cure? Is it going to be very expensive? Right? Two
Hmm.
main things. So for that, what is important is taking treatment in a place where there is a great team. It takes me a lot of time in counseling my patients and telling them, look, I don't cure you, our team does. It's the doctors and the nurses and the people who wash the floor and the toilet, and the pharmacy, the blood bank, that entire ecosystem. And this team has to follow the protocols for every patient all the time, whether this doctor is there or not there, whether this nurse is there or not there, the system has to work. So those places where you have good teams, a good ecosystem, are where they should take treatment, because then the chance of cure is the best, complications are as less as possible, and thus the cost will be less.
Right.
Right, cost increases because of complications, cost increases because treatment is not good, so the cancer comes back, so now you have to again treat it, right? So it's the team. and
Right.
and and we keep on battling with this, where patients think, no, 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 we have come here for you and we want you, and I have to kind of tell them, no, it's the team, trust the team, right? So I think that's what they should look for, not look for either brands of hospitals or even brands of doctors, but good teams which work together and give
Yes.
good outcomes.
Yes, actually, that the team approach really plays a major role in any treatment, and that's an insightful perspective that you have shared, Doctor. So, Doctor, as we wrap up today's session, thank you so much for sharing your expertise today and your work in advancing blood cancer treatment and making specialized care accessible is truly commendable, Doctor. So, thank you so much for sharing that as well with us.
Thank you so much. It was a pleasure.
And to our listeners, I hope this episode has provided valuable insights into navigating blood cancer treatment. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed and take care.